welcome you all on behalf of Urological Society of India and the Endouro4 Subspecialty Committee. To take the program forward, we'll start off with, I'd like to invite Dr. Rajiv TP to give the opening remarks. Could we have Dr. Rajiv TP for the opening remarks? Mr. Tinku?
Yes, Danish, can you start that?
Can we have Dr. Rajiv TP for the opening remarks, please?
Okay, sir.
Good morning, Dr. Deepak.
Morning, sir. Morning.
Audible?
Yes, sir. Very well. Loud and clear.
Welcome to all.
Thank you, sir. Thank you. We're all set. We're just waiting for an opening remark from our Honorable Secretary, Dr. Rajiv TP, and then address from our President. Then we'll get going with the program, sir. Mr. Danish, any issues? Seems like we have some issue with the connection part. Mr. Tinku, can you highlight on us? Can you highlight on this what is happening?
1 second, sir. He's just connecting that. I think few seconds. Yeah, it has started.
No, we need Dr. Rajiv TP's message first.
Danish, put Dr. Rajiv TP's message.
Good morning to everybody. I bring warm greetings from Urology Society of India to this. This is a very important.
I guess you can go ahead and play the President's message. No issues. I guess we can get the Secretary's message later. No issues.
Danish, you start.
Day for another subspecialty section.
No,
because
Dr. Rajiv
since 2017
we have in our vision document started subspecialty based functioning of Urological Society of India. And after pediatric urology, this is the second subspecialty where a great program interjournal has been planned. Dr. Ganpule has done wonderful job, and he has crafted beautiful program where the residents are going to debate. There are 6 topics of a debate, and that will end after 2 rounds in the balloon round, and that will earn the prizes. And then there are 4 zones. In 4 zones, there are again 6 debates, and there are 3 rounds. And in the final round, we will
Can you
find
send
out
Danish
the
number? I'm
winners.
not able to play.
And on 29th
So he has mixed
November,
up
that
upon.
is today, we started, and then 16th December.
Okay, fine. Can I get one person who's in charge of who's playing all these videos?
Danish,
sir.
you played from the beginning only.
Can
Yes,
I
sir.
get who's the person who's playing these videos?
Sir, this is Tejas.
What's your problem? Can I get to know the problem, please?
Sir,
If you can't identify the files, just ask us once.
yes. So, whose video going to play first, sir?
Dr. Rajiv TP.
Dr. Rajiv TP. Okay, sir. Just a minute.
Good morning, everyone. I welcome all of you on behalf of Urological Society of India and Indian School of Urology. Today we are having an interesting program. This is a program by the Endouro4 subspecialty session of Urological Society of India. Today they have arranged a crossfire in endourology. This is a very interesting one, convened by Dr. Arvind Ganpule, who is the convener of the endourology subspecialty session, and his team. Today we will having debate on various interesting and challenging scenarios in endourology among the residents as well as the consultants. This will be taking place zonal wise, and all the zonal winners will again coming into the semi-final session, and there will be again debate, and ultimately the finalist, there will be a balloon debate in endourology. This is a very interesting program by the endourology subspecialty session, and we have eminent consultants participating in the consultant group, and we have the residents as well. And the winner will be given a gold medal, and the runner-up will be having silver medal, and all the journal winners will be and runner-up will be given certificates. I wish this program a grand success on behalf of Urological Society and Indian School of Urology, and I once again welcome all the zonal presidents, past presidents of Urological Society of India, ex-team members from Urological Society of India and SAARC countries for this program on crossfire in endourology. Welcome, and once again all the audiences, and I wish this program a grand success. Thank you.
Thank you for that, and apologies for the mix-up because all the 4 zones are parallelly going on. So we have recorded messages from the office. So I guess that's a mix-up. So we'll want Dr. Anant Kumar, the President of Urological Society of India. Can you play a message from him, Dr. Anant Kumar, please? Mr. Danish?
Good morning to everybody. I bring warm greetings from Urology Society of India to this. This is a very important webinar organized by USI and ISU. And the program coordinator is Dr. Arvind Vanpule, who is in charge of endourology section. In this program, the people from R4 zone are going to debate on controversial aspects of endourology, like how to manage inferior calyceal stones, whether big stone, the mini perk is good or piecemeal good, RIRS versus mini perk, and many other aspects of controversial aspects of endourology. This is a very well thought of program, and debate is a very good way of learning, because in debate you learn and you hear perspective of both the sides, and then you may be able to take a very balanced decision. So debate is a useful aspect of learning, and I am very sure our members will participate in this webinar and listen to the debates on various aspects of endourology. Participating in this debate is very important. I know that there will be a one winner and there will be a runner-up and the consolation prizes. But I would like to congratulate all the people who are, all our members, all our students who are participating in this webinar. They are worthy of appreciation. And I also in advance congratulate to the person who will be the winner. The spirit of debate is very important. Participation in debate is very important. Winning is important. But even if you lose, don't lose your heart, because there is always a next time. And even in debate, you will learn a lot, which will help you in managing the patients very well. So with this, I congratulate Dr. Rajiv TP, Dr. Arun Chawla, Dr. Rajiv Sood and Dr. Arvind Ganpule to bringing such a wonderful concept and organizing this wonderful competition and debate. And this will open up new horizon in learning in USI. At the end, I would like to wish a good health to all my members. Stay safe, take care of yourself and your loved one and your families, and welcome you again for this wonderful webinar. Thank you.
Thank you, sir. And of course, we'll just hear to Dr. Rajiv Sood, our Honorable Chairman of ISU. And now, Dr. Rajiv Sood, please.
Urology Society of India, Dr. Anant Kumar, Secretary Rajiv TP, and my co-chair of Indian School of Urology, Dr. Arun Chawla. I extend warm greetings from Indian School of Urology. This is a great day for another subspecialty section, because since 2017, we have in our vision document started subspecialty based functioning of Urological Society of India. And after pediatric urology, this is the second subspecialty where a great program, interjournal, has been planned. Dr. Ganpule has done wonderful job, and he has crafted beautiful program where the residents are going to debate. There are 6 topics of a debate, and that will end after 2 rounds in the balloon round, and that will earn the prizes. And then there are 4 zones. In 4 zones, there are again 6 debates, and there are 3 rounds. And in the final round, we will find out the winners. And on 29th November, that is today, we started, and then 16th December, 23rd December, when we finish, then we'll go for the great final round. And this all has been organized by Urological Society of India with all the moderators, the participants of all the 4 zones. So this is true interjonal debate competition where entire country has been involved, entire urology has been involved, controversial but interesting topics have been taken. I wish all the success for this great event. All the best.
Thank you, sir. And before we get the debate going, we would like to invite upon our convener for the Endourology Subspecialty Committee, Dr. Arvind Ganpule, to brief the entire competition and then flag off the debates. Now, Dr. Arvind Ganpule, please.
Evening, seniors, teachers, and my dear friends. I am Dr. Arvind Ganpule, and I am the convener for this program. At the outset, I wish to thank USI ISU, Professor Anand Kumar, Professor Rajiv TP, Professor Rajiv Sood, and Professor Chawla for reposing faith in the newly formed USI Subspecialty Cell to conduct this debate contest. The USI Endouro4 Cell was established a few months ago by the USI, and this is the second program by this newly formed cell. I have been helped by a number of colleagues in arranging as well as conducting this program from the USI Society Cell. I would be unfair if I do not acknowledge them. I would like to thank Dr. Ragori, Dr. Gupta, Dr. Singh, and Dr. Zishan for helping me out. I would be unfair if I do not acknowledge the contributions of Dr. Rohan Batra and Dr. Karthikeyan from Trichy. All of them are moderating individual sessions today. I also would like to thank the team of judges, all heads and professors across 10 institutes in different zones. Thanks for sharing your time, sir. I would also like to thank IPCA for their coordination and support. Now coming to the program, the planning for the debate has been going on for the last 2 months. USI members were encouraged to participate in this contest through emails sent from the USI Central Office on 20th of October, 22nd of October, 28th and 30th of October. Responding to these email calls, those who expressed their interest through these emails and had reverted back are participating today. We received an overwhelming response as is evident from the number of debaters you are going to see today. Thank you USI members for the same. Today we have got 44 debaters in round 1 who will slug it out for the next 2.5 hours. There will be 5 Zoom IDs simultaneously running today at the same time. There will be 4 winners from each of the zone and 6 winners from the resident contest today. The participants would be judged on the following points. They will be judged on the content, literature support, fluency and style of presentation, punctuality and maintaining the time allotted, and finally rebuttal. All the winners will proceed to round 2, which is scheduled on 16th of December. The winners of round 2 will go to round 3, that is semifinals and grand finale, which will be conducted in the last week of December. The icing on the cake for this program is that presidents from all the zone and the USI President himself, Professor Anand Kumar, have agreed to give a few words of wisdom to the guest talk after the debate, and they are going to give the vision of endourology in 2021. I hope you enjoy the program. Let me sign off by saying to all my participating colleagues, seniors, and friends, winning is not everything, participating is important. Wish you all the very best. Over to you, moderators.
Thank you, sir. Thank you for the brief introduction and the kind words to all the participants. Now, I guess without any further delay, I'll take this debate forward. Now, let me share the screen, and there are 4 debates that are coming up. I would like to present it in form of a slide, and I'll give a brief introduction of the debate that is going to take place, and then I'll hand over it to the first speaker as such. And I welcome on behalf of the Endouro4 Subspecialty Committee all the participants, our Honorable President of the South Zone, who is also going to give a guest talk soon, our judges, and all the audience. I'm sure you'll have a very informative and a great time for the next 2.5 hours. To start with, we have 4 debates today lined up, and we will give you a brief introduction of all the topics that they're going to debate on as we go by. And to start off, I invite the first set of participants for the debate 1. They'll be debating on the lower calyceal calculus, which is around 2.5 centimeters with 1500 Hounsfield units in a solitary functioning kidney. The debate would be on PCNL versus RIRS. If I have to give you a brief history, which will save some time for the participants themselves, it is a 43-year-old hypertensive male that we're looking at with a history of right PCNL way back in 2003. And a history of right angioembolization for the post-PCNL hematuria and clot retention. And the differential function test which was done on a DTPA showed the right kidney was functioning around 6%, and now complains of a left flank pain since a month, on and off. And there are no fever history or lower urinary tract symptoms or history of calciuria. And that's the CT image for all the audience. That's a reconstructive image, and let's begin. I'll pass on this screen to the first contestant. Dr. Taif.
Morning, everyone. Is it visible and audible, sir?
Yes, you are audible and we can see your slides. Please go ahead.
Thank you very much for giving me this opportunity to participate in this debate. I'll be speaking for this case for PCNL. Like we know from the highlights of this case, we are looking at 2 aspects in this case. Basically, the burden of the past history of an unfortunate event versus the present situation, which is overwhelming from an RIRS point of view. Well, the major points of concern as I see is the stone burden of 2.5 centimeters, which is very high for RIRS, Hounsfield unit of 1500, a branched lower calyceal stone pattern, narrow infundibulum, acute ureterocalyceal angle, and a small pelvis. Would we consider RIRS as an option at all with this concern? I'm not very sure. Well, still, to go ahead with the formalities, let us see what does exactly RIRS offer to us in such scenarios. RIRS for a large lower calyceal stone, we have concerns of clearance, well, with the cutoff limits being 2 centimeters. Well, against that for 2.5 centimeters or something more than 2.5 centimeters, concerns of number of sessions needed is very high. And RIRS no doubt is considered very safe. There are a list of significant complications associated with it, which often get underplayed. There are a lot of technical challenges that we are bound to encounter here. Acute angle, narrow infundibulum, branched stone pattern, no space for scope manipulation, repositioning of stone being improbable, and irrespective of the extreme level of advancements, our scopes are still having a lot of limitations in negotiation. Looking at the literature, well, what is the feasibility? The so-called RIRS feasibility in stones larger than 2.5 centimeters, the average number of procedures needed is anywhere between 1.6 to 2.4. And the rates of complications can go up as high as 10 to 15% as well. Along with that, the moment you look down at the clearance in lower calyx per se, it drops down to as low as 50%. So is that a feasibility? Other studies also show that after multiple episodes, all you can reach is 90%. Subcapsular hematoma, acute page effects are also there in this procedure. And it has been highlighted, the minute lower pole location is there, a major limiting factor comes into picture. If you actually see the efficacy after first procedure for a stone of more than 2 centimeters, it's somewhere around 50 to 65% only. Well, coming into picture is the lower pole clearance, which is the predominant factor playing in this case. If there is an acute angle of less than 90 degrees, as in this case in the infundibulopelvic angle, and a width of less than 5 mm, you are looking at a clearance rate of only around 50%, which is a huge compromise from the patient's outcome. If you pitch RIRS versus PCNL in these case of scenarios of a lower pole, well, even though studies which compare are small, still the success rate is definitely in favor of PCNL. Well, then we are looking only at 2 centimeters. Stretch it up, extrapolate it up to 2.5, and it will way further higher in case of PCNL. Bringing into the picture the other concern of a solitary kidney. Well, solitary kidney RRS is not so-called safe completely. Successful clearance needs multiple sessions, and the complication rates are again as high as 15% as in this case, and something as deadly as stenosis leading to acute renal failure, sepsis, and dialysis can occur in such scenarios. And what is the success that we're looking at is after prolonged and multiple procedures of 2 to 3 hours each, and still at the end of all this, residual fragments remain. On the other side, what does PCNL offers to us in such scenarios? Well, we have an isolated lower calyceal stone, not a big stone from PCNL point of view. This stone will not require a supracostal puncture. You need a direct entry to lower calyx. Ultrasound guided will add in that extra amount of safety, and most probably you will be greeted with the stone touching the tip of your needle tip. Then why bother thinking about RIRS at all? Well, it's all because of the fear of the past episode, the fear of risk of bleeding. Well, can we solve this fear? Let's see, are there any factors to predict this bleeding and whether we can cut down on this risk and overcome our fear? Studies which looked into the risk of bleeding requiring embolization have found out that renal anomaly and large stone size are the major risk factors. Well, in our case, none of these are present. Other studies have also found that large stone size is a major risk factor. The complexity of the stone, need for multiple tracks, and in case the kidney was operated before are other major risk factors. We have none of these in our present study. Well, the only solution here is rational thinking, highlighted beautifully in this study, which highlights that the most important factor in predicting bleeding is the correctness of puncture. Stick to your basics, learn your technique properly, and you no longer have to run around about fear of bleeding. This is all we Indian urologists have been telling to the entire world for past several decades. And the biggest weapon in PCNL right now to overcome this fear is ultrasound. Gone are the days where PCNL transfusion rates were high 10 or 20% and angioembolization of 2 to 4%. We are extremely safe now. And even meta-analysis have proved beyond doubt that ultrasound helps in making the punctures better, safer, with lesser bleeding and lesser transfusion rates.
1 minute left.
The guidelines say that PCNL is the first line for more than 2 centimeter stone, and RIRS will need multiple procedures. The study which comes closest to our scenario of large 2 centimeter stone in solitary kidney shows that there is no difference in hemoglobin drop. Stone-free rates are almost double, and serious complications are actually higher in RIRS. The decision to select the better option is absolutely clear. So whether it is fear of bleed or a compromise and a stretched feasibility of a technique, the choice is ours. Thank you all for your attention.
Thank you, Dr. Taif. We'll pass on the ball to Dr. Siddhalinga Swami, who will be talking for RIRS. Dr. Swami?
Yes, thank you, sir. Am I audible, sir?
Yes, you are.
Yeah.
We can see your slides as
So,
well.
speaking on Pro for RIRS, we have to highlight the how that kidney is non-functioning. This is history. It's a solitary functioning kidney. I'm really surprised. How do you counsel this patient for one more PCNL? Will you explain angioembolization? This is a study from the Egypt which has clearly shown an increased risk of angioembolization in a solitary kidney. My friend has missed this table or this study while discussing this. Why to take this risk? My treatment of choice in this particular case is definitely RIRS. With RIRS, there is no puncture of the kidney, no bleeding risk, no transfusion, no risk of loss of function, mobility is less, no surrounding organ injury. It's a daycare procedure. Even the guidelines have shown more than 20 lower pole stone RIRS as an option. If I'm able to see the stone with my flexible scope and a laser fiber, surgery will be completed. On-field units of 1500, laser does fragment all the stones. This is possible in 90 to 95%. Less than 5% I have to defend with you, sir. So let us be practical here. PCNL is a very old procedure done for more than 30 years. Still, we have a lot of discussion, demonstration in conferences, especially on the puncture. Whatever said and done, it is still a blind puncture. RRS has been here for just a decade, and now we have so many youngsters who are doing an excellent RRS with minimal training. So what really happens, especially in this case, it's a densely impacted white-based stone involving complete lower calyx. The stone-guided puncture you will take, there will be risk of bleeding on the parenchymal tear. There is no space for you to guide park your guide wire. And once you have passed, if it is misplaced or if there is a kink, again you have to repuncture, which increases the chances of bleeding. So you will break the stone as fast as possible to place the access sheath. By the time you enter into the PCS, some of the fragments might have entered into other calyx. To remove them, you'll use excess of torque leading to an infundibular tear, and you end up in a bleeding kidney with a residual stone. What you have to do is just compress the kidney, pray the God, and leave it there. Let us review the literature. I'm not going to very detail about the literature. We have meta-analysis which are supporting us. We have 3 meta-analysis for the more than 2 centimeters PCNL versus RIRS, which have clearly concluded RIRS is safe, effective procedure. It's a comparable stone-free rate and a significantly reduced complications. That's what we need in this case. So this is a one more article with a lower pole stone of up to 3.5 centimeters, which are shown almost comparable with ultra mini PERC. Both have been safe with no major complications. Missed this table, which clearly shows the final stone-free rate of 100% in both the groups and the transfusion risk in PCNL group, but not in the RIRS group. Lower calcial anatomy, yes, El-Bassi has showed in 1988, as quoted by Taif, it is more than 70 degree, less than 3 centimeter, and more than 5 length. But infundibular length was not associated with the stone-free rate recently. And again, the increase in the deflection technology development as improved in surgical technique has led the flexible scope to reach the lower pole more easily. So now, even if it is an acute angle, once you go inside and see the stone, if you are able to see the stone, you will be able to clear as much as possible. As you can see in these pictures, we were able to reach that stone in an acute angle and completely clear it without any problem. So RIRS in the lower pole, there is no harm in going with a flexible scope and have a look at the stone. You can always fragment the stone and then relocate to the more accessible calyx. We do have a special fiber optic scope and a better lower calyceal approach. We do have special laser fiber modified to work better in these lower pole. Along with that, we have an access sheet with a suction, which will improve the residual stones clearance and better stone free rate. We have the upgrade of RIRS in this last 1 or 2 years. That is a disposable scope, holmium laser of 120 watts and a thulium fiber laser. What is best other than this case for the disposable scope? Ideal indication, especially in a large volume stone with a lower calcium stone. Even we can be more daring and bold to reach the stone without the fear of scope damage, and the vision of the vision is as good as a digital flexible scope. Holmium laser has an advantage, Moses technology greater advantage. Now we have Moses 2.0, 85% greater stone ablation with 120 Hertz and a superior ablation at distance of all the stone locations and compositions. So latest advantage is the thulium fiber laser. It's a great advantage for the large volume stones, what we are using in our institute. 1.5 to 4 times faster ablation rate as compared to the holmium. We can use up to 100 micron fiber, which will not affect your scope deflection. Duration of surgery is very, very less, so faster post-op recovery. I would like to share a case what we have done for a large volume stone in the lower pole. But when we go inside and see, we were able to see the stone incompletely. So we were able to basket that stone, put it into a more accessible calyx, and we started doing the thulium fiber laser. Initially, we used a high energy and frequency to fragment the stone as much as possible into multiple small fragments, and it takes around 38 minutes for this case to be completed. Then we used high energy and high frequency to completely powder it, and we have used an access sheet to completely wash that powder out. And once this powder is come out, you will be able to see the complete clearance there. I would like to share a similar case what we are discussing today. Typical lower calyx complete cutoff of the lower calyx was seen. When we go with the flexible scope, we were able to see the tip of the stone. When we start doing the case slowly, when we are able to chip a small part of the stone, we were able to enter into the calyx, completely clear that stone from that lower calyx, and complete clearance was possible. Even though it was a large volume, even though it is a lower pole, even though it is an acute angle, we were definitely completely clear that stone without any hazards or any problems. And you will be able to see the last RGP picture, which will show the acute angle which we were able to enter and clear the stone without any hazards or any problems here. So in this case, it's a solitary kidney. So it's a post-PCNL complication on the opposite side. Treatment of choice is 1 is RIRS, 2 and 3 always RIRS. Whenever possible, avoid this kind of picture on your solitary kidney. Thank you, sir.
Thank you, Dr. Swami. I think you have made your point very well as far as RIRS is concerned. I guess now it's time to give a chance for a rebuttal from both the sides. Over to Dr. Taif for your rebuttal. You have 2 minutes.
Yeah. Thanks a lot. I see that the only concern which is remaining here is fear, fear, and fear. We are not looking at just a technical feasibility. We are looking at success rate. Well, what about the complications of sepsis and urinary injury? It keeps on bugging again and again, but never have you heard PCNL bleed recurring you again. PCNL bleed is something like lightning and never strikes twice, unlike an RIRS sepsis. So we are not looking just at technical feasibility. We want to give our patient the best possible thing. And not just about bleeding. What about the ureter? Do you stop doing URSL if there is a ureteric perforation or ureteric damage, you leave RIRS? Well, this patient is also having a technically solitary ureter also. Do not forget that. I would still say that it is a fear of bleed versus a compromised and an extremely stretched feasibility running into multiple sessions backed by literature of small studies with few number of patients, which will say that after 2 or 3 sessions, maybe, yes, we may just touch the success of PCNL. Overcome your fear and success shall be yours. Thank you.
Thank you. Thank you, Dr. Taif. Over to you, Swami. Now it's your final chance to fire. 2 minutes.
Yes, sir. Yeah. So whether RIRS or PCNL, why you want a hole in the kidney of a solitary kidney? Forget about the ureter. The kidney is one here. So cost, most of the times it will be the major limiting factor for RIRS, but a high volume center can do RIRS on par with the PCNL charges. In PCNL, more miniaturization of the ampla sheet you go to reduce the bleeding risk, you definitely increase the cost of that procedure. Financial issues, RIRS is a disposable scope. We can get up to around 70,000 and access sheet of 5,000, whereas mini nephroscope itself costs you around 4 lakhs. So you are definitely on through which is the costliest one. Sepsis is very, very, very low, 0.7%. Not all post-op fever or sepsis. Aggressive medical management is more than enough in most of the cases. Taking the necessary precautions can prevent this. Why will I go with a fresh ureter? I will stent this case. I will use a bigger access sheath. I will be staging the procedure for more than 1.5 hours. Patient is happy to come back the next day again. We can get it operated again and again, but he will not be blaming you for the loss of the kidney function. Still, there is definitely no loss of renal function. Steroid will make a large of differences here. Is PCNL free of sepsis? No, you definitely mentioned a ureteric urosepsis is 0.4% overall. So why you want to blame it everything on the RIRS here?
You have
Finally,
30 seconds to wind up, Swami. 30 seconds.
Yes, sir. Relook versus humoral analysis, choice is left to the patient. Thank you, sir.
Wonderful. That's a great show from both of you. Well done. I guess both of them have very well made their points and within the time. And we'll leave the rest to the judges to take a call. We'll move on to the next debate. So I'll give you a brief intro on the next set of. One second, I'll just give a brief intro about the next set of debaters. Yeah, there you go. So coming to the next debate, it's about a 2.2 centimeter renal pelvic stone in an ectopic kidney. We are debating about a lap pyelolithotomy versus a retrograde intrarenal surgery. And the debate is between Dr. Nitesh Jain and Dr. Vikram Sridharan. So a brief history again, a 31-year-old male with no comorbidities presented with complaints of right lower abdominal pain. And that's about it. There's no much other complaints other than that for a period of 6 months. And the CT would show this, an ectopic kidney with a renal pelvic stone. I'll pass on the buck to the debaters now. Dr. Nitesh Jain, he'll go first.
Good morning, everyone. First of all, I would like to thank USI for giving me this opportunity. Well, I'll go straight to the business. I have nothing to disclose, and I love both laparoscopy and RIRS. Well, the case given is a pelvic ectopic kidney with a 2.2 centimeter stone. I'm debating in favor of laparoscopic pyelolithotomy. Let's analyze the case based on 3 factors: anatomy, size, and invasiveness of the procedure. So let's see. This is a pelvic kidney with anteriorly facing pelvis. The calyces are non-dependent. The stone is around 22 mm and the course of ureter is abnormal. We know from embryology and anatomy that most of the kidney, because of incomplete rotation, the pelvis is anteriorly facing. Many of them have associated abnormality in the form of PUJ obstruction. The calyces are non-dependent and the ureter is usually abnormal in course. So do you want to drive on a curvy road when you have a straight highway available for the same destination? Well, no. We can see from the below picture, the course of ureter in all this kidney is usually very tortuous. So most of the time we need multiple sittings in case if you are doing RIRS or may require a pre-stenting. So you need multiple procedures. You need experience to negotiate this curve and not all can be a shoemaker to drive on F1 course. So defying gravity, if we see the drainage in this calyces are anti-dependent, so we have to defy gravity. The clearance of the stone is less. Demikerson have demonstrated an ESWL role of ESWL in pelvic kidney with prone position, and it has shown that inferior clearance of stone in pelvic kidney. Around 22 to 37% of the patient can have associated PUJ obstruction in pelvic ectopic kidney. And all this can be tackled very well by laparoscopy. We cannot do anything about this abnormality by RIRS. So does the stone size matter? Definitely yes, in stone as well. So let us see the guideline and literature, what they say about a stone, role of RIRS for a stone more than 2 centimeter. Well, definitely EUA does not even recommend RIRS as the first option for stone more than 2 centimeter, even for the normal kidney. Forget about the ectopic pelvic kidney. This is a very interesting algorithm published by Singh et al. From Nadiad group in BJUI, where they have given algorithm for a pelvic ectopic kidney for more than 1.5 centimeter stone based on the Hounsfull unit, and they have given a laparoscopic or robotic or open pyelolithotomy as one of the first choice for a stone which is more than 1.5 centimeter. Mind you, here we have a stone of 2.2 centimeter. And RARS, even if it is done, it needs to be done in the stage procedures. So you need to do multiple procedures. So once we have dealt with the stone, have we cleared all the stone? Coming to the stone fleek rate.
Ergin et al. In the year 2017 have done a head-to-head comparison of laparoscopic pyelolithotomy and RARS for an abnormal kidney. And they have said that 100% clearance of laparoscopic pyelolithotomy for a stone of almost 28 millimeter size, much larger than the given case. And for the same 17 stone, it is only 84% for RARS. So the clearance is much inferior. There are different other studies, but the maximum clearance rate, even after multiple settings, is reported is around 84%. Here we can see the overall success can be as low as 20% for a RIRS, which is published by Lavan et al. Coming to the laparoscopic technique for the anomalous kidney, we can see the clearance rate is much, much higher. Almost most of the study have reported for a very big stone of around 5.5 centimeter or even 600 millimeter, the clearance rate is almost 100%. And coming to the complication, almost none of the study have reported any major complication in most of their studies. If you see the stone clearance rate in RIRS, it is only the maximum reported after a single sitting is only 75%. And even after multiple sitting, it is only around 99%. And that too, we have to wait for almost 4 to 6 weeks to see the clearance. And many of these patients have had 15% of the patient in RIRS group had complication of grade 1 and grade 2. And more than 2.5% patient had complication of more than grade 3 clavin. Coming to the invasiveness, I know my friend is going to grab me for this. Laparoscopy is more invasive, but tell me honestly, any of one of us like to take a hopping flight to go to a destination? All of us want to reach the destination in the shortest possible course of time. Same holds true for the surgery as well. No one wants to come under knife for multiple time, and almost everyone wants 100% solution versus uncertainty of RIRS. When come to the safety concern, there are multiple studies by Gupta et al. And Albanese et al. Which have reported laparoscopic procedure is a safe option for a pelvic ectopic kidney. Some of the information which are missing in this case are Hounsfield unit. Coming, if the stone is very soft, there will be more gravel, there will be more higher residual stone because the calyces are non-dependent. If the stone is very hard, then automatically it is not suitable for IRS because of the mere size. And the status of the opposite kidney is not known. Suppose if it is a solitary kidney, it is ideal to make him stone free with a single procedure rather than making him stone free or suboptimal clearance after multiple procedure. We all know the recurrence rate is very, very high if there are residual stone there in the kidney. So laparoscopic pyelolithotomy is a very versatile procedure which can be used for any size stone, any composition of stone, any density of stone. If it is lying in any calyx, we can use at times nephroscopy to remove stone in the inaccessible calyx. And in case if the patient is having any associated abnormalities, we can very well take care of it simultaneously. Thank you.
I guess it was very well put up in a nutshell. Now let's move on to the other contestant. Can you stop sharing, Dr. Nitesh?
Yes. Oh, sorry. Yeah.
Yes. Yeah, I think we'll move on to Dr. Vikram now to put his point forward. Dr. Vikram.
Yeah. Yeah, can you see the slide?
Yes, we can see the slides. We can hear you very well.
You can hear me? Yeah.
Yes, please go ahead.
Yeah. Good morning, everyone. Warm greetings from True Foundation, Trichy. I first of all thank USI and ISU, the convener and the moderators for giving me this opportunity to be part of this interesting program, Crossfires in Endourology. First of all, when the topic was given and the images were shown, I was wondering why there is a debate at all. Because when we think of 2.2 centimeter renal pelvic stone in a normally placed kidney, there is no debate about laparoscopy or RIRS. It is RIRS, more features in favor of RIRS. No one talks about laparoscopy. Then why now suddenly we talk about laparoscopy when the kidney is in a different position? Is it because we are afraid whether we don't know whether we'll be able to reach the stone, the ease of access? Is it about the fragmentation? No, fragmentation is done by the laser. Wherever the stone is, the laser will fragment it. And is it about the clearance? Yes, maybe the major worry is about the clearance. Let us go into this and look at what the literature says. My initial approach is to counsel the patient about primary or secondary RARS, as we do for all our patients, irrespective of whether it is a malrotated or unascended or anomalous kidney or a normal kidney, lap pyelolithotomy just for discussion's sake, and lap assisted PCNL. And here my personal choice is RARS. Why? Because ease of access, which I'll come soon. We have excellent stone free rate. We have minimally invasive and significantly pain-free option available. Can be done under regional anesthesia, which takes significance with current pandemic. Comparable operative time with any other modalities. And of course, it is safe. We have a great literature support right from 2005 till the recent ones that flexible ureteroscope is efficient and safe to handle stones in anomalous kidneys. Ease of access. As Dr. Nitish was saying, anatomically, the renal pelvis is facing anteriorly. In my opinion, anteriorly facing renal pelvis is a big advantage for RARS. As we break the stone will keep falling and we can give a complete clearance. And he was also mentioning, probably this is also part of rebuttal, he was also mentioning that there is possibility of associated POJ obstruction. How do we know whether there is a POJ obstruction if we directly go with a laparoscopy? Anyway, in this particular patient, there is no obstruction as seen evident in the CT images, but still RARS gives a very good chance for us to inspect the upper tract and the lower tract with semi-rigid scope. If we are lucky that day, then they have a good chance of straight access to the stone with semi-rigid URS. Of course, in tortuous and difficult accesses, we have flexible scope that can be used for clear access. And in case of stone migration, while we break the stone, we can always access all the calyces, move it to a favorable location and break it. Pre-stenting is not mandatory in all the cases. In our own series of 12 patients, the stone-free rate after the primary RIRS was 85% and remaining 15% we could clear with a second sitting. Stone-free rate obviously is improving the new generation lasers because we can create fine dust and have a better stone-free rate. Yes, the literature again supports us, and there is even a study from MPUH saying the position of the stone in the PCS and total stone volume are important factors in predicting clearance. Of course, in our index case, the stone is in the pelvis, 2.2 centimeters, and easy drainage is available. This is the only completely scarless treatment option available for stone in the anomalous kidney right now. And of course, there is no loss of nephron and very minimal postoperative pain. Most of our patients take only paracetamol and that's it. No other painkiller is used. And most of them go home within 24 hours after surgery, a very short hospital stay. We do it in spinal anesthesia, which makes it cost effective and affordable for most of the patients. And of course, this comes as very handy option in the current pandemic where we try to avoid general anesthesia for fear of infection. And we have literature supporting us saying RIRS is in spinal anesthesia is safe and has advantages of lower pain score. We have a comparable operative time of about 90 minutes and operative time is decreasing with increasing experience. Safety has already been established with several studies and more than 20 millimeters of stone located in the renal pelvis. RIRS is safe. If somebody is bothered about the fluoro exposure, now we have fluoro-free flexible URS, which most of us have started following. Why I am against lap? I would like to disclose we do advanced laparoscopy, PCNL, mini-PERC, multi-PERC, RIRS, everything in our center. But here, in general, this laparoscopy is a new surgical skill. Not everyone is comfortable with endosuturing. If we don't do the suturing properly, we have chances of urine leak and contamination of the peritoneal cavity. This needs a completely different set of instruments, whereas most of us will have laser and flexible scope to proceed with the RIRS. And this needs general anesthesia as opposed to spinal. And some patients may need bowel preparation. If people, after watching our friends' discussion, if they think laparoscopy has a straightforward road to the stone, no. There is lots of small bowel distension. If the patient is small, thin built, then we have difficult access. So that also needs to be considered. Exposing the urine contamination inside the peritoneum, urine is infected, so we have to, that is of great concern, and it is unfair to break the neighbor to clear your house. No significant advantage in operating time, and of course that ever troubling shoulder pain related to pneumo and pain at the incision site, which is definitely higher than the RIRS. This picture is worth 1,000 words. As you can see, we could have a complete clearance of the stone with the semi-rigid ureteroscope itself, and this video plays it. This is bigger stone than our index case. This is 2.5 centimeter stone. We had a straight access with the rigid ureteroscope. As you can see, we can have a very nice vision. This 2.5 centimeter stone was almost filling the entire renal pelvis, so initial breaking was slow, but as we started getting more space, it was faster. 75 minutes of lacing time, we have complete clearance with the semi-rigid ureteroscope itself. This is a CM image on table. This is an X-ray taken 20 hours after surgery and 15 days after surgery, and the stent was removed with complete clearance. This ureter has a tortuous course like what our index image shows, but again, as you can see, we have an ease of access that the semi-rigid ureteroscope can straight away enter into the renal pelvis. This is a left renal pelvic kidney.
You have a minute to go, Dr. Vikram?
Yeah, this is another image of a left pelvic kidney where in tortuous ureter, we can have access with the flexible ureteroscope. This image was borrowed from my good friend, Dr. Datsun Josh. Yeah, as you can see, ascending straight, we are bang on the stone. Once we break into fine dust, we will have complete clearance. To sum it up, RIRS doesn't need separate skill. Already our endourology skill is enough. The instruments required are same as endourology except for laser and flexible ureteroscope, whereas LAP needs a completely different set. This is the least invasive. If somebody says LAP is minimally invasive, you have to compare with open, not with endourology. And anesthesia can be done under spinal, comparable operative time, and very minimal postoperative pain requiring nearly nil analgesia, and 100% stone clearance is comparable with the laparoscopy. Thank you.
Thank you, Dr. Vikram. That was just on time. Perfect. So now it's time to cross words again. We'll pass it on to Dr. Nitesh for your rebuttal. 2 minutes, Dr. Nitesh.
Well, my friend has said that we cannot know PUJ obstruction before. Do you do any surgery without imaging? Most of the imaging will tell us whether the patient is having a PUJ obstruction or not. Pre-stenting is avoided, but not in all cases, and you need multiple surgery. He himself have admitted in his talk then quite a few number of patients needed pre-stenting, and the clearance was only 85% after first procedure, whereas in laparoscopy we talk about clearance of almost 100% after one surgery. Laparoscopy, usually you hit the target right away. Here you have to make some amendment to do the surgery. Why are we afraid? Experience, we need it for all surgery, both for endosuturing as well as RIRS in case of anomalous kidney. Both the surgery needs experience. It's not for novice. Hospital stay, most of the laparoscopic surgery can be done as daycare, and we have got a large series of laparoscopic and robotic surgery, right from robotic prostatectomy to nephrectomy, adrenalectomy, where we have done daycare surgery, and it has been published as well. Radiation, RIRS has got risk of radiation, and do you want to radiate the genitalia with genitalia around? Cost of surgery, essay to cut down the cost of surgery. You are giving spinal anesthesia. Mind you, most of the patients are more comfortable in general anesthesia. And there are a good number of studies which say that general anesthesia is much safer as compared to your spinal anesthesia. He said urine is infected into the peritoneum. In case the urine is infected, you cannot do RIRS. Definitely RIRS contraindicated. Only if the urine is sterile, you are do. Otherwise, it's much better to do your pyelolithotomy if the urine is infected. Invasiveness of the procedure. Well, let's see. Single sitting versus a multiple sitting. Which is more invasive? You are asking the patient to come for 2, 3, 4 times for a same procedure, or a single sitting procedure where the patient is stone free and he can go back to his work without any mental agony. Till the stone is not cleared, he will always be under pressure. There is something inside him. Intrarenal pressure is all.
Dr. Nitesh, your time is up. We'll wind up. Yeah. Sorry, we'll need to be very sharp, very harsh on your timing. We're doing it as a competition basis. I'll be ruthless as far as time is concerned. Over to you, Dr. Vikram. 2 minutes. Time starts now.
Yeah, I think most of the questions have been answered in my first session itself. Unfortunately, there are not many papers that support Sir's views. The papers that he presented, the maximum number of patients were only three. The number of papers that support RIRS and renal ectopic kidneys are very, very minimal when we compare to number of papers supporting RIRS. That means this is easily doable. Most people can repeat it. Any procedure needs replication. So more number of people doing it comes with more number of papers. Less number of people doing it comes with less number of papers. That means it is difficult to learn. No one wants to come under the knife multiple times. This was said by Dr. Nitish. Of course, recurrence rate is higher. So next time when the patient comes back with similar stone, will he again cut the patient? No, I will not. But I can again do a RARS. Probably the next time when I do it, the chances of finishing it in single sitting will be much higher. That's not the same in laparoscopy. Coming to the spinal anesthesia point of view, the patient, we have the habit of making the patient watch the procedure as we are doing it. Patients are very happy. Trust me, they see their enemy being broken in front of their eyes and giving a complete clearance. They are able to enjoy the procedure, and this education is done, and even counseling for multiple sittings have been done preoperatively. That doesn't stop us from doing RIRS. If we stop doing RIRS for want of second sitting in non-anomalous kidneys, then the same goes to the anomalous kidneys also. Thank
20
you.
seconds to wind up. You're
Thank
done?
you.
Wonderful. Perfect. I guess that comes to the end of this second debate. And let's move forward with the next one. That would be debate number 3. Let me introduce you the debaters. So we are going to discuss about a 1 centimeter stone, which is around 1200 Hounsfield units in the upper calyx. We're debating between mini-PERC versus ESWL. Dr. Vinod Kumar and Dr. Sudarshan Balaji will be slugging it out. A brief note on the case we're going to discuss. It's a 42-year-old female with a history of right flank pain since 7 to 10 days, colicky in nature, radiating to loin to groin. And there are no other complaints like nausea or vomiting. That would be the CT image, a 1 centimeter stone located in upper calyx. We'll pass on the buck to the other 2 debaters now. Over to you. And the first one to go would be Dr. Vinod.
I'm sharing my screen, sir.
Yes, please. Go ahead.
So is everyone able to see my slides?
Yeah, we just see your slides. Go ahead, Dr.
So good morning, one and all, respected teachers, my dear colleagues. I'm Dr. Vinod Kumar P, consultant urologist from India Hospitals, Bangalore. I thank USA ISU for providing me the opportunity to participate in this endourology debate. I am going to talk about mini-PERC for a 1 centimeter upper port calculus. So I hope you all know the case. Just to brief you about the details, she is a 42-year-old female with right flank pain. CT scan shows upper pole calculus of around 1 centimeter with an HU of more than 1000. So let's begin with the basic mechanism of stone fragmentation. As we all know, shockwaves in ESWL fragment the stone either by a single or combination of forces like spallation, shear stress, etc. In spite of which, sometimes there are residual fragments resulting in strain stress. But on the other hand, the same stone can be dusted completely using laser by photothermal mechanism. It is like comparing bullets to olden day arrows for shooting. Any operative procedure is defined by success rate. Similarly, success rate here is measured by stone clearance rate at the end of 3 months. So when I went through the literature, there are only few studies showing head-to-head comparison between mini-PERC and ESWL. These 3 studies by Kruk et al. 2012, Kumar et al. In 2015, and Soleiman et al. In 2016 have clearly shown that the stone-free rate at 3 months is much higher compared to ESWL, ranging somewhere between 80 to 95%, making mini-PERC a clear winner here. I know that Dr. Sudarshan might argue saying that the last 2 studies have taken lower pole calculi into consideration, but the case in our scenario is having an upper pole calculus. To this, my response would be the stone location doesn't have significant bearing on the stone clearance in ESWL, as shown by these 3 studies by Madboli et al., Obek et al., and Joan et al., published in Journal of Urology. Lower pole anatomy definitely reduces the stone clearance, but the results are not clinically significant. Overall, clearance rate is definitely poor irrespective of calyceal location, making ESW a loser again. But on the other hand, when we talk about mini-PERC PCNL, The stone free rate ranges somewhere between 75 to 95%. This is a meta-analysis by Farakis et al. In 2014, which includes about 15 studies. 3 of them are randomized controlled trials, where the initial stone free rate is around 75 to 95%, making Miniperk again a winner. Harder stones do not easily break with shockwaves of ESWL. A meta-analysis by Brice and Nevada et al. Showed that stones HU of more than 600 and 600 to 800 HU are associated with high failure rate following ESWL. But this stone, in this case, this becomes important in our case because the stone is around 1100 HU. But this stone doesn't pose any challenge to Miniperk. These two studies by Kumar and Solomon et al. Also compared need for auxiliary procedure following ESWL, and they have said that at least 1 in 5 cases need auxiliary procedure following ESWL. Even the EU guidelines mention that medical expulsive therapy and diuretic therapy can significantly improve stone free rate, but Miniperk doesn't need any additional support in this tug of war. Retreatment rate is also higher in ESWL. As we all know, ESWL needs multiple settings for stone fragmentation. The lady in our case also has a stone which is HU of more than 1000, so she definitely needs more than one setting for breaking the stone. But the same stone can be fragmented and dusted completely within no time using laser during Miniperk. It is like comparing an electric saw to an axe for cutting the wood. Most of us might think that ESWL is less expensive compared to PCNL, but when overall costs were considered, we were surprised to see that PCNL is more cost effective compared to ESWL. These quotes are directly from an Indian paper and a UK paper showing that ESWL is more expensive when overall costs were considered. Regarding hospital stay, Miniperk definitely has a longer hospital stay, being an invasive procedure. These studies have shown that the average hospital stay ranging between 2 to 4 days for Miniperk, and ESWL, most of the time it is daycare procedure. But it is an unfair comparison to compare an invasive and a non-invasive procedure based on the hospital stay. But with the advent of coronavirus and the online work from home, I don't think patients are really bothered by the slightly longer hospital stay. However, with advanced instrumentation, tubeless procedures, miniaturization, there is significant reduction in hospital stay. The meta-analysis by Zhu et al. Here clearly shows that there is significant reduction in hospital stay in Miniperk PCNL compared to conventional PCNL. Common belief is that ESW is not associated with any complication and is very innocent, but EU guidelines clearly mention a table of complications following ESWL, and it is definitely too much for a so-called non-invasive procedure. Miniperk has far lesser complications and lesser morbidity than conventional PCNL, again shown by the meta-analysis by Zhu et al. You can see here clearly that hemoglobin decrease and the VAS pain score are significantly reduced in Miniperk compared to conventional PCNL. Miniperk has more complications as it's an invasive procedure in comparison to ESWL, ranging somewhere between 5 to 10%. But this amount of complications can occur with any operative procedure, and I don't think patients will not choose Miniperk fearing these complications. कुछ पाना है तो definitely थोड़ा कुछ तो खोना पड़ेगा. Thank you.
So you're muted, I guess.
You're muted, sir.
Sorry about that. Thank you, Dr. Vinod. Your point very well made. We'll pass it on to the next debater, Dr. Sudarshan. You ready?
Yeah, just a second. So I'm sharing my screen. Yeah. Is my screen visible?
Yeah, you're visible and audible. Go ahead.
Yeah, a very good morning to all. Thank you for the opportunity, and I take a good hi to say to all my seniors and colleagues. And the topic given has been discussed by Dr. Vinod is a 1 centimeter upper calisal stone. And as we see, shockwave lithotripsy in 2020, it's best reserved for stones up to 1 centimeters, and more than 2 centimeters, there is no question. And between 1 and 2 centimeters, that's where the actual debate is. The stone in consideration being 10 millimeters. And this is the most naturally available modality to break, and the patient passes the stone by themselves. And we all know the different advantages. Let us go through all of them. both the AUA and the EAU guidelines recommend shockwave lithotripsy as the primary modality for stones between 1 and 2 centimeters. And for a stone of 10 millimeter, I don't know why are we debating here. Now, yes, the previous generation, most of the things have inappropriate case selection, which led to slightly poorer results. Now, let us see how actually we have got to top up the ESWL results. Here we can see the EAU 2020 guidelines, which shows shockwave lithotripsy or endourology as the option modality for a 10 millimeter stone. Now, what are the factors which we consider before making this critical decision? Now, the stone characteristics, as we can see, the stone size is the primary discussion in point, where I do understand that in shockwave lithotripsy, where the stone size is between 11 and 20, that is up to 10 millimeter stone, the success rate for shockwave lithotripsy is close to around 80%. And in PCNL, definitely it comes to around 85 to 90%, but not without its own risk and hazards. As we can see here, the big available paper, Indian paper, where we have the largest single center experience of more than 5,000 patients, the success rate for ESWL has been close to around 80%, but this is considering only the stone size. If we take the location of the stone into consideration, definitely the success rate improves by a fair bit of margin, where the upper calyx is showing equally a good success rate of around 80 to 85%. Now, one can argue that the stone location, does it really matter at all as far as PCNL is concerned? Yes, it does matter. Whereas we can see here, Sharur et al. Clearly mentioned that the upper pole calyxal stone undergoing PCNL is an independent predictor of incomplete stone clearance, and stones within the pelvis and the middle calyx were more likely to be cleared than the stones in the upper or the lower calyxal location. If we can see through the Smith nomogram, upper calyx location was associated with the lowest clearance rate, inferior even to stones within the lower pole. So definitely there is more chances of bleeding with the upper pole palaeal puncture also. And the stone in consideration, if we can see in the subsequent slides, is based much higher, where we have to get access through the above the supra 11th or at least the supra 12th puncture will be required in this particular patient. Now, yes, I do agree that the ESWL has a restriction as far as the stone composition is actually concerned, but we do know that where the ESWL is not going to work, these details are not given in this particular patient. But looking at the stone, it's a more homogeneous. The HU is around 1100 to 1200 ounce field unit, and there is no lamellated appearance which is visible on closer magnification. So I do really can rule out a calcium monohydrate stone in this patient, and in all probability, it looks like a calcium dihydrate stone, for which I'm sure the ESWL can be given. And the stone attenuation values, yes, there are multiple studies which have shown the different cutoff values where shockwave lithotripsy can be used. But in Indian patient population, mostly 90% of the stones were calcium oxalate, and predominant of which are monohydrate stones, almost close to 75, 3/4 of these patients. So with most of the stones having an attenuation value of 1000, more than 1000 Hounsfield unit, and the average Hounsfield unit in our Indian population has been close to 1200. So it would be really unfair to actually have a cutoff value as per the guidelines to be 1000. We will definitely be missing out on a particular modality in total. Leave out no consideration of different patients. We'll be losing out there. No other Indian patient can undergo a shockwave lithotripsy if we go strictly according to the guidelines. So we have a paper by Shah et al. And Jagtap, where we have really seen the cutoff values between 1200, where patients with Hounsfield units less than or equal to 1200 had lower number of shock required, and intensity of shock requirement was also less with better clearance. As we can see here, it's an upper calyx stone, favorable location and good infundibula width, and the Hounsfield unit is also favorable. So I don't find a need why we should not use ESWL in this patient. Now, the patient characteristics are important. Both of them have their own considerations, but these details are obviously not given in this particular case scenario. So let us not go into the details. Each of them have their own requirements. Now, different studies, as have been mentioned in the literature, have been showing poorer results for shockwave. But we do have to notice that there are different recommendations given by the EAU in 2020 guidelines, which have been serially built up over the few years with particular literature support. Now, these are the summary guidelines which are given in 2020, where we can see the slow rate shockwave lithotripsy has got an improved success rate as against the previous 120, limiting the shockwaves to 60 per minute definitely has lesser injury and definitely has a better clearance rate. And also 300 pre-treatment shock waves definitely improves the success and minimizes injury, and gradual power ramp up can also decrease the complications. And is there a problem with the total number of shocks? No. Limiting the total number of shocks to 1,500, which are good enough for a whole field unit of 1,000 to 1,200, definitely reduces the complications and improves the clearance. And if you find a residual stone, definitely it can be treated with rebooster, reshocks within a day or so. Proper acoustic coupling is important, and pseudoanalgesia to limit the pain and respiratory excursions are definitely improves the success rate. Now, as we can see, as mentioned by Dr. Vinod also, a mechanical percussion and diuretic therapy increases the stone-free rate but never impedes them. Now, most of the complications in ESWL is going to be minor grade, Clavin grade 1 and 2 complications, as can be seen here in this paper from Jagtap et al. But percutaneous nephrolithotomy has got a lot of grade 3 and 4 complications, and fever and transfusion requirement is high, and bleeding hampers vision. See, one can argue that mini-pug has a lesser invasiveness compared to PCNL, but definitely no one can argue that all said and done, mini-pug is going to be a sort of a blind puncture wherever it is in PCNL. And definitely one can never argue that mini-pug does not cause or that does not require an angioembolization. Definitely a situation can arise. And intrapelvic pressures are equally high. Yeah, intrapelvic pressure is definitely high. And head-to-head comparisons, as we can see here, shockwave lithotripsy definitely has a slightly lesser success rate, but at the cost of much lesser complications in favor of ESWL. Definitely it is non-invasive with safely procedure. And another paper by Risolo et al. Also signifies a similar findings where a slightly lesser success rate, but definitely much safer option. And auxiliary procedures, though required a higher, those are very minimal, like a stenting, which is anyway done in the case of mini PCNL, which requires a stent removal, which should be considered as a second procedure. Thank you. I'll wait for Dr. Vinod to speak again.
Wonderful. So that was pretty much on time. If you can stop sharing the screen.
Yeah.
Great. Now we'll get back to Dr. Vinod again for his rebuttal. You have 2 minutes, Dr. Vinod.
Thank you, Dr. Sudarshan. Are you able to see my slides, sir?
Yes, please go ahead.
Yeah. So I'm again back for the rebuttal. Please bear with me for another 2 minutes. So Dr. Sudarshan mentioned that EU recommends SWL as the first choice for 10 to 20 mm stone. But if you look at this carefully, the flowchart is about conventional PCNL and not mini-pug PCNL. However, text below mentions about mini PCNL, but without any size criteria. He also mentions that there is an Indian paper showing a very high stone-free rate of around 80 to 85%, including about more than 5,000 patients. But it is a retrospective study which is subject to potential confounding factors. And the stone clearance here was assessed by X-ray and USG, which can lead to observer bias and is much lesser sensitive compared to CT scan. The Sharao et al. Paper mentioned by Dr. Sudarshan also regarding predictive factors and outcome is again a retrospective study. And if you look at the univariate and multivariate analysis in the same paper, upper pole calyceal location definitely has lesser stone clearance in mini PCNL, but the results are not clinically significant. The Smith et al. Paper in 2013 is an nephrotic nomogram, which is a component of 6 parameters, and the overall score dictates stone-free rate and not only the calyceal location, as mentioned by Dr. Sudarshan. So the comparative studies mentioned by him are all between shockwave lithotripsy and conventional PCNL and not mini-pug PCNL. But the case in our debate is between mini-pug and ESWL.
You have 20 seconds to wind up, Dr. Vinod.
So he himself said that there are ways to maximize outcome after ESWL and ramping proper acoustic coupling. But this shows that ESWL is an inefficient procedure and needs auxiliary procedures or additional ways to improve clearance. So why do you need such an insufficient procedure? Complete procedure is the need of the hour. Complications are definitely seen, but with advent of mini-pug PCNL with tract size of less than 15 friends, there is a significant
we are time up, Dr. Vinod. Sorry, we'll have to cut it out.
Thank you.
Yeah. If you can stop sharing the screen, we'll move on to Dr. Sudarshan. His final 2 minutes chance to rebuttal.
Stop sharing.
Don't worry, Sudarshan. Once your slide is up, I'll switch on the timer.
Yeah. Yeah, so I'm starting my time now.
Go ahead.
I'm not able to move my screen. Just a minute.
Just click on the screen once.
Yeah.
Yeah.
Now, the first thing which we should know, the Hippocratic Oath, is first do no harm. In the quest of we doing something, we are obviously submitting, there is definitely a more invasive procedure. When something else less invasive is possible, we should opt for it. Now, as we can see, a lot of the face-to-face comparisons between PCNL, there are only very, very limited, only one study which compares mini-perk with ESWL, which I will show you. In the set of the network meta-analysis and systematic review, they have definitely concluded that the size of the stone and the location of the stone was not taken into consideration. So really, it cannot be taken as a benchmark for the particular case in question. And the cost invasiveness definitely cannot be, because the paper was biased. Initial investment cost was included, and travel for cost of stent removal not considered, and patient charge based on the number of shocks received. And it is for the institution, not for the patient. Now, overall steen stress complication is close to 8, but we can see that up to stone of 1 centimeter, it is going to be very less. And for stones located in the upper calyx, definitely the incidence of steen stress requiring further procedures is going to be very, very less. Now, one cannot be always lucky to have a very good puncture like this. The situations given mentioned below can definitely arise. These are the point of dreaded concerns. And definitely, I'm going to show you significance of images, which can definitely tell you why we should always reconsider the options of, mini-perk and sort of invasive procedures, when something less invasive is definitely going to be possible. Now, you don't have to be fast and furious always. Let us be sometimes slow and steady. The race is not always to be swift, but to reach the deadline. Now, the case in question has a 10 millimeter stone. Size is favorable. The site is favorable. The Hounsfield unit is reasonably favorable. Exit system is favorable. Composition is favorable. And fewer and minor complications, and less pain and lesser hospital stay. So slower clearance, I don't mind counseling the patient for going slow on this, and informed auxiliary procedures definitely can be done. Now, if the stone does not fragment, you can always booster at the second day. And still, if it doesn't fragment, accept the defeat and go for more invasive procedures. But when something less invasive is available, definitely go for it. And mini
Time is up.
no, thank you.
Wonderful. Wonderful. Good.
I'll stop sharing my screen.
Yes, please.
Thank
That's
you.
about it.
Thank you, sir.
I guess that's been a wonderful debate. And now let's move on to the last and the final debate. Yeah. So coming to the last debate would be a 23 millimeter stone in a renal pelvis, approximately 1200 Hounsfield units. We are fighting out between mini-perk and a standard PCNL. So this is between Dr. Gopal Tak and Dr. Altaf Khan. So to brief the history, it is a 51-year-old male who's a diabetic and hypertensive on medications, complains of left flank pain on and off for a month's time. So that would be the CT image. Another reconstructive image for you all reference, and then let the debate begin now. I would call upon Dr. Gopal. I think he'll be taking the talk first. Yes, Dr. Gopal, can you unmute yourself?
Yes,
I'm not able to hear you.
good morning all.
Yeah.
I am debating for 23 mm stone in renal pelvis, 1200 HU, in favor of mini-perk. So what is the ideal treatment for a stone? It should be less or non-invasive, less hospital stay, minimal complication and morbidity, quick complete clearance and low cost. So there is evolution of ampulla size from 42 to 30 to now less than 20. So with the advent of new technology in optics and lasers, many PCNL come up. The silent feature with one-step dilatation technique, stone fragments are washed out by turbulence of irrigation fluid called eddy current effect, and low intrapelvic pressure because of open ampulla sheath. So it was defined as a percutaneous nephrotomy with a 12 French modular miniature nephroscope with either 12 to 20 nephroscope sheath. Negle has designed in various sizes. Since then, mini-perk has become standard treatment for treatment up to 2 centimeter in a stone. So there is an evolution. PCNL was developed for large stones, and then we gradually realized that we can still go smaller from standard to mini without any increase in morbidity. So for a given case, why should I choose mini-perk? There are a lot of advantage and literature support. So is there blood loss is more? No. So the prospective head-to-head comparison of mini-perk with PCNL showing significantly less blood loss, favoring the mini-PERC. Can we go tubeless? Yes. The Udo Negle has published. He is the pioneer in mini-PERC. It's a prospective study of 67 patients. All the patients underwent tubeless mini-PERC and with 92% clearance rate. So what are advantage of tubeless procedure? So better patient comfort, less post-operative pain, short hospital stay, and quick recovery is given in this review of literature. The stone-free rate, coming to stone-free rate, Lamhe is also one of the pioneer in mini-PERC, has published a mini-PERC as an alternative treatment modality or replacement of conventional PCNL, concluding that clearance rate is equivalent to conventional PCNL and recommended for stone more than 1 centimeter or stone in the lower calyx or renal pelvis. Again, the same study has shown that the clearance rate was equivalent to the PCNL with a p-value of 0.4, that is not statistically insignificant. So initial stone multi-institutional studies has been done for mini-PERC, showing stone-free rate ranging from 80 to 97% for the size 1 to 3 centimeter. So there is an addition of suction to the mini-PERC has improved the stone clearance rate in the mini-PERC. This is shown by Dr. Kaushik Shah in the super PERC. The stone clearance rate was 96% and hospital stay was only 31 hours. So addition of this suction, the suction mechanism is outside the telescope, thereby allowing use of working channel continuously for laser fragmentation. In contrast to conventional PCNL, irrigation fluid goes in via working channel, which can be compromised while using grasper lithotripsy or laser fiber. Coming to the operative time, though some people are saying that operative time will be more in mini-PERC, but that is not statistically significant. Systematic review and meta-analysis has been already shown that. Coming to the hospital stay is also less, favoring the mini-PERC is around 3 days in this prospective study comparing 1 to 2 centimeter. The complication rate, there is a meta-analysis showing comparing mini-PERC and PCNL. The total complication rate in mini-PERC was 11 to 37% as compared to PCNL 16 to 60%. The same study of Udo Negle, he has a prospective study, 67 patients for a mini-PERC, no one had bleeding and sepsis. Now this was around up to the stone size 2 centimeter. Now coming to the larger stone, the BCOER published with the PCNL for larger stone, the high efficacy and safety and comparable to the conventional PCNL for more than 2 centimeter size stone, including complex diagonal stone. In this study, the stone free rate was 96% for simple stones and complication rate was 12%. That none required transfusion. Now the study with mini PCNL over standard PCNL, what makes better? It's a review article concluded that mini PCNL is effective as standard PCNL with less blood loss in small medium sized stone 10 to 30 mm. Stone burden is key determinant for stone free rate and can be done for even complex stone cases. So mini PERC for staghorn calculus has also been done with none required blood transfusion or bleeding complication was done in the Chinese study, prospective study. And at the end, the CROWS, multi-institutional CROWS global study has also shown that sheath size was a predictive factor for bleeding complication. So what is current status? Mini-PERC has advantage of PCNL, but with less complication, less hemorrhagic complication, and can be is an attractive procedure for treating the renal stones. We'll go through the quick representative video. It is a 22 mm stone. Just last week we operated single puncture, single track. After track there is no bleeding, and intraoperatively we are fragmented with the lithoplast, removed with the forceps. So the vacuum cleaner effect can also be seen here. The combination of forceps and vacuum cleaner effect gives the stone clearance. You can see the stone fragments which are collected over the drape. Complete clearance is achieved. No tubeless, it was done tubeless, and patient post-operative hemoglobin drop was only 0.2, and patient gone next day to the home after catheter removal. So now what is ideal treatment? It is less invasive, less hospital stay, minimal complication, quick complete clearance, and cost. So ideal treatment for the given situation is mini-PERC. Thank you.
Thank you, Dr. Gopal. And I would recommend you to switch on your video. We couldn't see you. We'll see you soon for the next stop. Yeah.
Okay.
So we will can you stop sharing?
Yes.
We will pass on to the next debater who's going to come strong at you, Dr. Altaf.
Sorry.
Yeah, there you go. Dr. Altaf Khan, you can take over now. We're not able to hear you, Dr. Altaf. Can you just speak out, please?
Yeah, you can hear me?
Yeah, please. Go ahead.
My screen is visible?
Yes, please. Go ahead.
Yeah. At the outset, I would like to thank the USI, the ISU, and the Endouro4 Society of USI, and also the convener, Dr. Arvind, and moderator, Dr. Deepak, for giving me an opportunity to speak on this crossfire. It's the first of the kind it has been conducted. And I would like to also thank Dr. Gopal for minimizing my time for commenting on the standard PCNL. So here you can see this, all minis are not attractive except for some like Mini Cooper or other thing. What we got to know is it is the end result that is more important rather than the procedure. Coming to the short recap of the history, here is a 51-year-old male who is diabetic and hypertensive, complaining of flank pain. So this is the image. I can see a particularly a very good hard stone in the pelvis, around 23 mm, and with a wide infundibulum of lower calyx, which can easily access more than 30 French sheath without any problem. So 23 mm pelvic calculi, definitely PCNL is the way to go, but which size? Coming to a short history from Jackman, who first started this mini PCNL, he did it for PCNL in pediatrics. But now trying to extrapolate this PCNL from a pediatric to an adult patient is a little more. And also further innovations that led to the development of multiple ultra mini, micro. What is the problems with this mini PERC? Mini PERC irrigation definitely is compromised because of the small channel. Once the irrigation is slow, the vision is also compromised because when the instrumentation is also used, the vision is more compromised, and even a small clot can obscure the vision. Retrieval of fragments also will become a big challenge, and also the raised renal pressures also can cause post-operative complications. So in terms of stone-free rates, we know Dr. Gopal has already told that standard PCNL has got more than 90% stone-free rates in more than 20 mm stones compared to mini PCNL, which has got just 76%. And also this is one more study by Shame, where the stone-free rate was significantly lower in case of mini PCNL. Coming to bleeding, Dr. Gopal was telling that bleeding is very less in case of mini PERC. But the bleeding doesn't depend on the size of the sheet or anything else. It depends on how you puncture and where you puncture. It is also the complexity of the pelvic calyceal system. And as there is progression of bleeding, then it is very difficult to continue with the mini PERC because the vision gets obscured. So here is a like short video. You can see a small mini PERC. Bleeding can happen just at the time of puncture also. So bleeding can never be an excuse for not making it a standard. Even in case of a renal biopsy, you can have bleeding because of aneurysms and all. So in short, it is not the size, but that perfection that matters. In the post-operative period, you can see that the operative time is also much reduced in case of standard PCNL, and complications are not much when compared to mini PCNL. The mean operative time is significantly lower. If you see all those studies, the standard PCNL is just 31 minutes compared to 45 minutes. How does it matter? Yeah, definitely this operating time matters because when there is, in case of mini PERC, because of the high intra-renal pressure, the more amount used increase the pressure within the kidney pelvic system, there can be fornical rupture, there can be bleeding, there can be obscurement of vision, and then also there can be post-operative stress, and especially in this case when the patient is a diabetic, you can have expect some sort of complications in post-operative. And also in case of mini PERC, the small fragments will be very difficult to retrieve sometimes, and because of laser, the fragments become so small. Sometimes the fragment can go into the upper calyx, and it may not be able to retrieve. Whereas in case of a standard PERC, we can just break into a large fragments and we can extract it without any problem. And this is a study wherein you can see there is a comparison of renal pelvic pressure and the post-operative fever incidence. So to conclusion of this study, NEM-PCNL was correlated with both higher renal pressure, pelvic pressure, and increased likelihood of post-operative fever. So whenever a patient comes to us, he wants to know that how fast he can go. With all these complications in the back of your mind, you can never tell that, okay, with a mini PERC, I can discharge him within a day or two. Whereas in a standard PERC, I can discharge him within a day. Even I can make it tubeless, and we can make it a daycare. Most of the centers will do. And cosmesis, does it really matter? You can see here the regular standard PCNL on their left side and the mini PCNL. Some people can get a keloid scar or anything. So it doesn't really matter about the cosmesis. And coming to the parenchymal damage, taking a study by Oliver Trax, which concludes that renal parenchymal damage resulting from the creation of nephrostomy tract is small compared to overall renal volume, regardless of the size of the nephrostomy tract. Consequently, there is no advantage to the use of small access sheath based on renal scarring alone. And also a study by Moskowitz it suggests that the PCNL does not alter the global and regional renal function in short term as detected by the DSMA scan. Coming to conclude, I would like to take some point from Thomas Knoll, which he says that using superlatives for marketing is dishonest to a patient as it raises expectations that might not be fulfilled. Maxi complications may occur even with micro access. Size might matter, but what matters more are the right indications and a skilled surgeon. So mini PERC in this case, no. A big thank you. I quote from GD this paper around 2007. So I rest my case here. Thank you. Thank you, Doctor.
Thank you, Dr. Altaf. I guess you made your point very well. Now it's time for Dr. Gopal to give a brief rebuttal. Dr. Gopal, we would like to see you, please. Can you switch on your video as well? Yes, please. We can see you now. Go ahead. Now you have 2 minutes to give your rebuttal. Yeah, go ahead.
My colleague has said that there is a less irrigation problem and there is a visibility is clear. But to know that when we can flush with the ureteric catheter from below, so it will increase the vision also. And intrapelvic pressure will be low because we are using around 12 to 20 sheath and nephroscope will be 12 French only. So I already told that suction, this improves the visibility by irrigating from below, and addition of suction also helps in that. Coming to the operative time, the individual studies may be showing that operative time will be more in the mini PERC, but the systematic review and meta-analysis, they have shown it is not statistically significant difference. Coming to the complication, all can be attributed to the tract size, like bleeding, perforation, calcial infertility here, persistently, pain and nephron loss. Does the size of tract matter? Yes. The factors affecting, this is the landmark paper, factors affecting the blood loss during PCNL. The lesser the size, lesser is the blood hemoglobin drop. And so what problems that occur at the time of dilatation, like kinking of guide wire, under dilatation, over dilatation, pelvic perforation and calcial tear. Along with that, there is a significant risk of radiation exposure in standard PCNL. It's how you explain to the patient and yourself that 10 mm hole, nephrostomy almost compulsory, more pain and blood loss will be more in case of PCNL. So now which procedure is better? The answer is simple. It is mini PERC and the only mini PERC. Why to take chance of more bleeding, more pain and more hospital stay? So effectively more cost bearing by the patients. So it is the ideal treatment as already said initially also. So mini PERC has an edge over the PCNL. Thank you.
Thank you, Dr. Gopal. I guess you have made your point in crisp and short form, and we'll give one last chance to Dr. Altaf to defend himself. Dr. Altaf, you have a couple of minutes to finish off the debate.
Yeah, you can see the slides?
Yes, please. Go ahead.
Yeah, while we are going through a rebuttal, I was thinking whether it is still required because already I have told that the damage of this thing, renal parenchyma is not much compared to a mini PERC or even the bleeding. Bleeding is not because of the tract size. Actually, it is because of your perfection of how you puncture. And bleeding can occur even after the post-operative period because of aneurysm or anything. The main thing is whenever a patient comes to me, he will ask whether kitna lagega, how much is the cost. So cost will definitely be more in case of minipack because of the frequent damage to minipack scope and the laser if we have got to use. And also the second question will be whether it will be cleared, whether sub एक ही बार में खत्म होगा क्या? Yeah, definitely I can guarantee that with the PCNL 99% that can clear the stone. So post-operative sepsis also is one more concern here because of the high pressure within the system. They can have infection which can cause, because of intravasation of fluid, and especially in this case because of diabetes, it can more chances. And also there can be pharyngeal rupture because and lead to bleeding because of the high intrarenal pressures. So coming to all this, I just think mini work is not the choice for this particular case. Though we can do it from other when the anatomy is very narrow infundibulum or we are not able to access the pelvis through the narrow infundibulum, then definitely yes, but not in this case. Thank you.
Thank you. Wonderful. I guess both of you have made your points, and we'll leave it to the judges to take a difficult decision of who's going to be the winner. Can you just stop screening stop sharing your screen, Dr. Alta? And I congratulate all the participants. All 8 of them have wonderfully stuck to their time, and they have given their talks as well as the rebuttals. Now it's time to invite our guest of honor and our to deliver the president's talk, Dr. Ganesh Kamath sir. Please do share your screen and give your talk on the president's perspective of how 2021 is going to be as far as endourologists are concerned. Meanwhile, we'll await the results from the judges, and I'll come back with the results of the debate once this talk is done. Over to you, Dr. Ganesh Kamath sir.
Thank you, Dr. Deepak. Are you able to see my screen?
Yes, sir, very well, and we're able to hear you loud and clear.
Good afternoon, everybody. I'm grateful to the esteemed colleagues in USI and ISU, convener of this particular session, and zonal moderator, Dr. Deepak, for inviting me to participate in today's academic initiative. Hearty congratulations to all the debaters for making this morning worthwhile. The theme given to me is a little tricky. Firstly, I have just 32 days to reach 2021, and I'm not sure what cataclysmic changes can occur during this period. Second is, whenever we are asked to talk about endourology, we immediately jump to technology which is going to make a difference to the next year or the future ahead. I decided to depart from this trap. In order to look ahead, one has to look back. This is an oxymoron. However, this is reflection. Reflection has got 4 different elements. One is to investigate, ask questions, incubate, ruminate about the question and answers, illuminate, that is, think about, define the ideas, the answers which you get, and finally, implement those ideas and start teaching. COVID-19, without exception, has disrupted life across all disciplines globally in 2020, and I will dwell on our learning process of challenges faced and how we will emerge better equipped in 2021. What happened in 2020? There was initially a paralysis where one's survival was at stake. Endourology work was halted like any other clinical specialty, with resources, hospital beds, manpower, and material being diverted to the care of the COVID-19 patients. And then followed a partial recovery with triaging of care and emergency surgeries resumed. Thereafter, in fits and bouts, we have restored our practice to varying degrees of normalcy. This is an example of how urology consults came down because of this problem, and only acute urology consults started being treated. So what are the challenges 2020 posed to us and which will result in different practice scenarios in 2021? I will dwell on three areas: patient care, which consists of consultation, diagnosis, triaging, and I will touch on remote intervention if it's possible, postgraduate training, and social media. Consultation. What we see today in is telemedicine was something which was practiced in the Middle Ages, where European physicians would see attenders of patients who would carry the stories as letters, and they would also carry a flask containing the urine of patients for diagnosis. Today, we practice telemedicine or remote consultation. Remote consultation is very well in practice, but what the problem areas here are diagnosing and triaging. Now, this could be one of the future of remote imaging, which is the handheld portable scanner, which, when appropriately paired with a smartphone like an iPhone, can transmit the disease or the problem area to the consultant, and he can take a decision as to whether this situation is acute or non-acute and indulge in triaging. One of the commonest situations in endourology is the stone. So one has to decide whether the patient needs home management or hospital admission. Once you decide that home management is proper, there are several apps which have come in which can aid in management of this patient. Apps provide an opportunity for urologists to engage with patients and offer a reference tool that can be accessed anywhere and at any time, and the increasing creation of such apps has been useful in the management of non-acute cases. Here, the patient has to enter the data regarding the location, size of the stone, the pain element, and it will give him a rough indication as to whether he is going to pass or not pass the stone. Such apps are going to come in the future in 2021 and will definitely help in remote management of patients. So what do we expect in the next year? We expect robust online consultations, remote diagnosis with lab and imaging, decision on triaging, whether home care or acute care in the hospital, and intervention will hedge on remote interventions in the end. Coming to the next part of my talk, this is on postgraduate training. Without doubt, postgraduate training has taken a hit. Urologists have traditionally received surgical training through the Halstedian apprenticeship of seeing one, doing one, and teaching one. However, during COVID, resources have been diverted, urology wards were taken over, doctors across specialties were recruited to meet the manpower shortage, and close to 6 months of hands-on PG training was virtually non-existent. In such a scenario, virtual reality and simulators will be the backbone of future teaching, especially till we get past the restrictions posed by such pandemics and man-made or natural calamities. Training in endourology using simulators will see a huge acceptance in the future. Mentoring such simulated training, developing models for skill assessment with gradient level of difficulties will be the future. And I fancy an addition of the third, fourth element in this scheme, the introduction of the examiner. I'm almost tempted to add this might be prove a good tool to examine candidates for their proficiency in the specialty and may form a part of the qualifying examination module for endourology fellowships in the near future. The third part of my talk is on social media. Websites publishing unmerited articles often utilize titles that generate curiosity and lure readers to click on the article's link. This is commonly referred to as clickbait. With digital advertising being a multi-billion-dollar industry, sites can employ tactics to attract users at the expense of scientific accuracy. This burgeoning deluge of social media posts in 2020, offering treatment and cures for stones, cancers, and prostate, separating fact from fiction, can be a challenge. If you look at this graph, during the early part of the pandemic, in the first month, saw a record number of views on Facebook sites, scam sites. Many were related to the pandemic in question, but these are real problems in our specialty as well. A significant amount of the circulating information is commercial, biased, and misinformative. 2021 may see the emergence of tools using artificial intelligence and machine learning to detect and combat such misinformation sites. Finally, coming to the last part of my talk, which is what is the future of remote minimally invasive intervention? We're all aware of the nanorobots which are in circulation for delivery of chemotherapeutic drugs. And this is what is known as the Bristol bot. Now just imagine, I'll leave you with the scenario as part of my talk. Imagine a home-managed ureteric colic with the calculus impacted in the upper ureter, not responding to medical expulsive therapy. You are the endourologist sitting at home. Sitting at a console in his home, you can guide the intervention. The tiny bot is inserted through the urethra like a urethral suppository, guided by a GPS, can travel to the site of impaction, remotely tracked by you sitting at home, and fragment the calculus by a remote trigger, and then it can self-destruct its biocompatible construction. Thank you.
Sir.
Dr. Deepak?
Sorry about that. So we were just discussing about the results. So I apologize. Thanks for the talk, sir. Thanks for the talk, and it was very enlightening. So I have the scores with me, and I'll go one after the other. The first debate, when the judges will be anonymous, so I'll not be disclosing who's who. And the first debate between Dr. Taif and Dr. Siddhalingaswamy, the winner is Dr. Taif. Congratulations. And the second debate, which was between Dr. Nitish Jain and Dr. Vikram, the winner is Dr. Vikram. Congratulations.
Congratulations.
That's debate number 2. Debate number 3, it's between Dr. Vinod Kumar and Dr. Sudarshan, and the winner came out to be Dr. Sudarshan. Congratulations.
Congratulations.
And the most trickiest part for us, the fourth debate between Gopal and Dr. Altaf. We're still finalizing because it has come out as a tie as of now. We're still working on a few scores. We're working on that. We will announce the result in a while. Just give us a minute because we're still working on it. Okay. So
Morning, Ganesh sir. It was an excellent talk.
Hi, Sudarshan. Congratulations. Congratulations.
Meanwhile, I would like Dr. Ganesh sir to give some words of advice and congratulatory messages to all the participants and how you felt about the whole debate, sir. I'll just take a minute to close this. Thank you.
First of all, let me thank you guys for organizing such a very nice initiative. See, the whole part of debate is it sparks off two things in you. One is the ability to sift literature, and the second is to argue out your case based on the merits. Sometimes in a debate, you may not actually believe in what you're fighting for because you may be practicing something different. But this is about life. Life is about accepting everybody in your scheme of things. So in an institution, if you have 4 modalities treating the same disease, you have to accept that another colleague will do something else for the same problem wherein you will do something else. So this is the general principle of life. Accept everybody, but create the debate in your mind because it's useful for you to proceed in life.
Thank you, sir. And the biobot concept which you are conceptualizing was something very innovative. I don't know how you got hold of all those pictures, everything to demonstrate.
No, but this has been working in my mind for a long time. Once you start looking at seeing fiction movies, science fiction movies, you can put yourself in that position. And I don't think it's far off. See, somebody sitting in US can trigger off a bomb to explode on some target in the Middle East. You can capture Osama remotely. So we have the technology, and military technology has often been utilized in civil practice, especially in medicine to a great extent. So if we can harness that kind of technology, I don't think there may be another generation which will see this in practice.
True, sir. Agree.
So, I mean, I had a super challenging task of finalizing the result of the last debate. That's between Gopal Tak and Dr. Altaf Khan. So, guys, it is like there was nothing between you two. The score is just as similar as both of you. So, bang on. We had few other parameters to consider during the course of debate in case of a tie. And the final result, I would say, with just a millimeter of a fraction, the winner has been declared as Dr. Altaf Khan. Okay, but well done, Dr. Gopal, yourself. But there was actually nothing between you two, but yes, there has to be one winner, and so whatever the parameters we had to take a call. And I once again congratulate all the debaters, irrespective of who the winner is or not. Like Dr. Ganesh Kamath sir also has told, we have learned a lot from the debates and the points that you have put forth, and it's been a wonderful few hours that we have spent. I'll finish off this session with a couple of more slides. Where we're going ahead with this, and I've just declared the winners of all the debates, and I didn't have time to fill this blank, so excuse me. And I congratulate everybody whoever has come out trumps in this initial debate. And we have circulated this the rounds 1, 2, and the dates that the subsequent rounds are going to take place. Now that we're done with round 1, the next one to be looking forward is round 2. And as the results from other zones also evolve, we'll come out with the fixtures for round 2, and then come out with the program schedule again. It is scheduled for December 16th. And then the finals is going to be on 23rd of December. That the picture of this would be clear once we get the results from round 2, as we all know. And I once again thanks everybody. Thank you, Dr. Ganesh Kamath sir, for being with us, and all the participants. You have done a great job. Keep participating, and we'll all see you soon again.
Thank you.
Thanks a lot. Thank you.
Thank you.
Good day.
Thank
Have
you.
a nice day.
Have a good day.
Thank you. Yeah, Doctor. Tinku and Danish, I guess we're through with the show.
Yes, sir. Yeah.
Yeah,
So,
I guess.
So shall we stop streaming as well, sir?
Yes, only one thing
Yes,
is
yes.
we should